I'm John Sobure. I work as a community health officer for CMMB. So CMMB stands for Catholic Medical Mission Board. So it is an organization that is geared towards improving the health of women and children worldwide. And it has a signature program known as the CHAMPS program, that is Children and Mothers Partnership Framework. So it builds on strategic partnerships with key stakeholders and communities for long-term impact on their lives. That is to be able to deliver result-driven and evidence-based interventions. As an organization, we intend to be able to respond to leading determinants of morbidity and mortality among women and children. So our long-term commitment to working with these communities has allowed the Catholic Medical Mission Board, along with other partners, to develop locally owned solutions that attend to barriers to access maternal, newborn, and child health services. So the program focuses on the root cause of poor health and high mortalities towards maximum impact. So we are guided from by a gap analysis and detailed mapping of the households and individuals and the quality of healthcare while increasing the capacities of these communities, of the community health volunteers to be able to promote health-seeking behaviors and provide the basic curative services and referrals for comprehensive care to the health facilities which they are linked. So the CHAMPS model was developed in 2012 and it is now fully operational in defined catchments, that is in Haiti, Kenya, South Sudan, Peru, and Zambia. So our evidence-based theory of change is based on the reasoning that when services are accessible and they meet basic safety and quality threshold, the demand, this demands results and sustained demand for yield of adoption. 388 CHVs have been trained and they're currently using the Smart Health application. So there are 52 health facilities that have been linked to the platforms where these CHVs work. And the CHVs are able to refer any sick cases or any cases that need the attention of the healthcare workers. So currently they serve a population of about 192,000 people, that is in Kitui South. And the focus is intervening during the first 1,000 days of life. You all understand that during this time is when irreversible damage can be done, especially on nutrition and some developmental milestones to a child that can make this vicious cycle of maybe poor health determinants go on and on in a community. So the cascade of care has been measured from using some indicators, that is the 4th ANC. We are also looking at the skilled birth attendant and then the newborn care indicators, immunization indicators, and some wash indicators too. Look at the mHealth application, our journey. Probably CMMB has been, I think, in partnership with Medic for longer than the Smart Health application that you're able to see there. So it started with an SMS-based platform, whereby CHVs were able to navigate through a workflow that was SMS-based, using the basic mobile technology that has been able to be evolved over time. And currently, the CHVs can be able to boast about having a smartphone and an application that they are able to carry out ICCM assessments, that is for pneumonia, diarrhea, and any sick child danger sign. And then they are also able to carry out immunization and growth monitoring activities, or register the same in the application. And then they are able to do monthly screening, especially for pregnant women, for HIV and TB status of the population. And then they are also able to input some data on the wash status of that household. So this journey began in 2016, and it had only 41 CHVs. That was the first pilot that was conducted. During that pilot, some of the results from the pilots included a backdrop of about 29.7% performance in the SBA. That is when we use the source, that is the KDHIS2. So 77% of the mothers followed up on the platform were able to deliver at the health facility under the under skilled birth attendants. So that informed, I think, more advocacy for digital health, showing that this could actually improve the health outcomes. So the standard platform was rolled out in 2017 and 2018, targeting 350 CHVs. And it later evolved to now the current MEDIC application that we use. So it has 18 indicators that cut across the RMNCH cascade, and this has been done across the 6 wards in Kitui South sub-county. Package of intervention as an organization that we normally offer is we do advocate. That is, we want the community health volunteers to be able to be supported by the county leadership, by all the interested partners to be able to have the capacity, the equipment, the tools to be able to carry out community health services. So we do training and equipping of the CHVs with tools, for example, a smartphone, bicycles, job aids. We also give them the tools that they need to carry out ICCM in the community. Then we also offer supportive supervision. So there's this lead CHV cadre that has been in place to be able to offer supportive supervision. And also we are using the government public health officers to be able to now take support the whole system. So we do routine data analysis, and we support the county to be able to analyze data that is being collected from the application and from other sources, and be able to make informed decisions when it comes to how they want to improve the system. Today, our major focus will be on the pregnancy workflow, because we've been able to have demonstrated better results or more better indicators when it comes to pregnancy. So in the application, the CHV is able to fill in a pregnancy workflow for all the pregnant women in the catchment area. So once they have been able to register these pregnant women in the application, then they are able to track these women over time and then instill the behavior change health messages into these women, and they are able to follow the guidelines for better health outcomes. So the CHV is able to receive tasks in the application, and also they get SMS notification to be able to follow up on these women. For example, they are able to get an SMS notification to inform them that a particular woman is due for their next ANC visit. So they will be able to maybe follow up this woman and see if the woman actually went to the facility to get ANC services. So the CHVs continue to educate the mother on danger signs in pregnancies, and this is able to be tracked by the supervisors and the decision makers when it comes to health in the sub-county, and they're able to actually support when necessary. So the data from the platforms informs health facility-driven additional support. For instance, if women are registered more, or more pregnant women are registered for a particular period of time, and their EDD is due, then the equipment or the supplies for ensuring that all these women, if they were to land in a facility, they are for delivery, that will be able to be tracked. So This has also informed some additional initiatives that we are carrying out as an organization. For example, the Linda Uzazi. So Linda Uzazi is an initiative that came about when women were not able to go to the health facility for ANC services. So more advocacy, more incentivization needed to be done to have these women visit the facilities for ANC services. So this actually came from the data that we were seeing in the platform. Women are able to be registered, they go maybe for their first ANC, and then they disappear, and then maybe you'll see this woman when she has delivered. So again, another initiative that came about, or that has been really, that has come about, is the SBA Champion Initiative, whereby the data that you are seeing from the platform informed us that women could maybe be registered on the application and they are not able to be delivered at the facility. So what was causing this is lack of transport and the high cost of maybe transportation from the community to the facility. So as a program, we've been able to put in place a model whereby these women can be transported to the health facility for delivery. So all this has come about from the, I think, harnessing the technology and being able to see data that is being provided and actually informing some of our programming. And I think now we can be able to boast of about 80% deliveries for the health facility deliveries. I think this has come down from about 27, that is in about 2017, thereabout, when we didn't really use this technology. Some of the challenges that we've been able to probably face while using this application has been a slow uptake of optimized utility of these devices. So when the rollout was done, a majority of CHVs took some time to utilize this facility, the devices. So you'll do a training for these CHVs, and then we have this system whereby we are doing double reporting for our CHVs. They use the application, but to some extent, when they want to report to government, they have to use papers. So sometimes they feel, because the papers are what goes into the government and it goes into the system, then that is important. So that has brought about some slow uptake of these devices. So CMMB works in the last mile communities. I think this is the most interior. Some of you have been able to visit down here and see the area. So the network coverage is not very good in some catchment. So this brings about maybe somebody having to travel a bit to be able to access internet so that they can be able to maybe sync their data so that it can reflect in the dashboards. So again, we have frequent MOH staff changes, whereby you will find the MOH being transferred, and then the actions that they need to do in their end not being able to be done. Key challenge that has maybe been a pain in the program is lack of electricity in some parts. So again, these devices need to be charged. So some CHVs have to actually travel some distance to get somewhere they can be able to charge these phones. So again, I've mentioned about having the both systems of paper and phone for reporting. When we look at just the impacts that or the lesson learned that we've been able to see, the percentage of skilled birth attendant deliveries has increased from 39.6 in 2017 to about to 82.9 in 2021. That is the close of 2021. So the proportion of women attending for the fourth ANC has increased from 29.4% in 2017. Now we can actually boast about 62% of women attending their fourth ANC. So the CHVs actually have been able to testify that when they're using the taskbar on the phone, they are able to schedule their tasks more effectively. They can be able to see which population are much more in need of their services, where do they need to do maybe a pregnancy follow-up, maybe referral follow-up and the rest. So it has made their scheduling of visits very easy. And then CHVs are able to track pregnant women more effectively. Now they have a small database in their phone that has all the women, all the pregnant women, and they are able to see actually these women. They're able to know when are they due for their next ANC visit and then visit them. So the proportion of fully immunized children in the catchment has risen from 63.5% in 2017, that is for the under ones, to 79.1% in 2021. So again, thanks to technology, we are able to see some good improvement in terms of the indicators that we track. So thank you, and back to you, Esther.
Any questions from the wider team that's here?
Sorry, just one question, and sort of an operating reality for us as well is, how do you get around the issue with internet connectivity? Because we picked that up at our clinics as well. Is there anything that you're doing to get around it? We're also sort of situated in places that's a little bit out of most of your urban areas, so we struggle with the same things from time to time. Also, electricity might be a challenge nowadays as well. So just wondering what you did to get around all of that.
Yeah, I think that's a good question, and yes, in fact, when we started this, the initial pilots in 2016, the connectivity status of the county was much worse than what it is right now. You could only get proper connection, probably stable connection, maybe 2-3 parts at most in the entire sub-county. And one of the things that we worked on very quickly with MEDIC was a design that would be able to work offline, so that once a CHV is back onto where there's proper connectivity, then the data is able to sync. So that has been a major issue, but I think we're also glad to and thankful to the government of the day, because there's been a lot of progress in terms of just increasing particularly electricity connection and internet connectivity and mobile phone connectivity across the sub-county. And this has significantly improved the way people communicate and move around, facilities communicate with each other. And ultimately now our CHVs are able to communicate fairly easier with their patients, with the facilities, and also with us in terms of just when they need support. But I want to note that we are not out of the woods yet. I think for us, the bigger issue even right now, beyond connectivity, is that some of our very high volume facilities are not yet connected to main grid electricity. So they're not able to provide some services. And this remains something that we continue to advocate and lobby with some government departments, because a lot of times, you know, the funding to support that is there, and the other times it's withdrawn. So it's nothing stable and reliable. So, you know, I think the conversation is much bigger than, you know, just connectivity for us.
Thanks. Appreciate the feedback on that one.